Are you ready to be connected? You're listening to the Insured Connection podcast by Pica Group, a pro assurance company, where we provide expert advice for your practice when you need it most. We connect you with industry leaders to discuss timely topics so you can listen, learn, and get back to caring for your patients. Now, let's connect.
Welcome to the Insured Connection, the podcast where medicine meets risk and where the lessons we don't always learn in training become the ones that matter the most in practice. I'm your host, Dr. Krupa Patel, and in each episode, we bring you real-world insights, stories, and strategies to help you navigate the clinical and legal complexities of patient care. Because understanding risk isn't just about protecting your career, it's about delivering better care. Today, I'm joined by Dr. Lisa Levick, a board-certified podiatric physician and surgeon, nationally recognized for her leadership in podiatric medicine and her commitment to advancing clinical education and patient safety. Dr. Levick is a nationally recognized speaker who has lectured at numerous conferences, including the Podiatry Institute and the ACFAS Annual Scientific Conference. She's a fellow of the American College of Foot and Ankle Surgeons and sits on the ACFAS Education Scientific Affairs Committee. She is also the proud owner of her own practice, Levick Foot and Ankle Institute in Northbrook, Illinois. Dr. Levick, thank you so much for joining me today. I'm really looking forward to this conversation.
Thank you so much for having me.
We're going to start this one a little bit differently, and we're going to start with a story. So, Dr. Levick, I'd love for you to take us into a real moment, one of those situations where it's a post-op call that just sticks with you, the kind where everything could potentially go wrong, goes wrong.
Yeah, and I feel like I should rename it to like the post-op call that never happened.
Yeah.
And what I mean by that is, I'll never forget this case to this day. It haunts me. I had a patient where I did a endoscopic gastric release and topaz procedure. And she was, I think, about 3 weeks out. I saw her a couple times for her couple, right away post-op appointments, and everything was fine. 3 weeks out, she comes to see me and she's livid. She is
Monday morning.
Like, yeah, beyond herself. And I'm like, oh my God, what did I do? Like, what is going on? And she's like, I have been calling the office for the past week and no one's gotten back to me. And I'm sitting here being like, I haven't gotten a phone call. What is going on? And she's like, I have been calling for the past week. My entire right side of my leg is numb. I can't feel it. And I have burning, shooting pain going down all the way to my toes. And I'm sitting there like trying to like take it in, but I'm also freaking out in the back of my head being like, wait, what's going on? And she's like, I can't feel the side of my foot. I don't know what's going on. No one's called me back. I talked to the front staff and she's giving the names of people who she's spoken to. I've talked to so-and-so, I've talked to so-and-so, and why haven't you called back? Why haven't you called back? And she's yelling at me, but also like you can tell she's in so much pain, and I'm trying to calm her down. And I try, you try to listen. You really don't know what's going on. So she's just telling me that this started out of nowhere and everything was fine and she had no trauma, nothing happened. She didn't fall. She's still in the boot. She denies, nausea, fever, chills, vomiting, shortness of breath. Because I'm thinking like maybe this is like a DVT. Like I don't know what's going on with her. And when she was talking about the numbness, I'm like, all right, let's see what's going on. So I'm testing her Sams-Weinstein. I'm testing sharp dull sensation. And like it is clear the sural nerve is damaged in some way. It is the entire course of the sural nerve. It's going like up into the calf. And I'm like, there is no way I cut this sural nerve. There's no way. Like I scope so well. I'm looking at it. I use the long Q-tips to make sure there's no hemorrhage in my area. I'm using, 1% lidocaine with epinephrine, making sure there's like literally not a blood spot in my area so I can see what's traversing in that area. And I swear to God, there was nothing in there, but things happen, right?
Right.
Sometimes we don't see it. Here we are. And there's something that happened. So I'm freaking out because time is of the essence. Because if I cut this sural nerve, the time to go see a nerve specialist is usually within the first 6 weeks. So I'm freaking out in the back of my head, but also I'm like harboring this anger because I'm like, what is going on? I was not notified by any of this. And now we've got like this major trust issue between us. So
What did you say to the patient when she's sitting in front of you, obviously irate, upset, and now, in your brain, you feel the red flag coming up. Like this is a serious problem, right? You've now
right.
clinically gone
So
through all the scenarios. So now
totally.
what do
So
you
like, it was so tough in that situation because you kind of like black out, right?
Yeah.
And when things happen, you black out. You're like, I don't know what to do. Um, so I remember saying to her, I'm going to leave right now. I need to go figure out what happened because this is unacceptable. And I just made her feel like what you are saying to me is valid. I need to go figure out what happened. And it wasn't really for her. It was really a moment for myself because I was so distraught. And I sat in my office and I remember thinking to myself, like, I've got to protect myself right now. Of course, I want to protect my patient and I want to figure out what's going on with my patient, but I have to protect myself. So I remember like writing down the things that I was going to do and taking like a moment, taking a beat and being like, okay, these are the things that I'm going to prioritize right now. I'm going to go call the podiatrist who only does nerves. She's on the south side of Chicago. I'm going to call her right now, get her in, and tell her this is like an emergent situation. Number 2, I'm going to order a stat EMG nerve conduction study. Number 3, I'm going to go talk to my staff later on. Like that's a whole nother issue, right? And number 4, like I just need to prioritize the trust that this patient has with me right now because there is an issue. Like I recognize there's an issue. I need to address this issue. So I went back in the room and I said, I still don't know what happened. I'm so sorry that this happened because this is totally unacceptable. And when you call, you should be directed to me immediately. There should be no gaps in time that you should be able to speak to me. But more importantly, your foot is what matters and getting you the sensation back is what matters. So here's what we're going to do and laid out X, Y, and Z for her. At that point, I gave her my Google cell phone number. So she had that so she could directly call me if there was another issue. And it was one of those things where we eventually got her the care that she deserved and everything went well. Yes, the sural nerve was cut and it was repaired and she's doing great now. But that gap of time sticks in my memory like none other.
Yeah, because that's the gap of time where it gets really interesting, right? Those 3
Yeah,
weeks or the 2 weeks where you hadn't seen her, you'd already seen her for first post-op, and now she's calling, unbeknownst to you, right? Many of these cases really, they don't fall apart in the OR, right? A sural nerve injury is a known complication. It's a known issue that can happen with the EGR and the procedures you did. Unfortunately, these are the moments where, all of these cases unravel, right? When you look back, you're thinking, it's not even under my control, right? Maybe it was the staff, it was the protocol, whatever. But this is like really the important point that we're trying to stress because we're not just talking about clinical judgment, right? You went through a differential. As soon as she sat in front of you, you're, oh my God, DVT, is there an infection? Is there some wound dehiscence? Is there a nerve injury, right? But
right,
we're really talking about not just clinical judgment, we're talking about communication, perception, timing, right? And you said you really
correct.
wanted to validate this patient because one, she was upset, right? Yeah, she didn't get a call back, right? Whether you got the message or not, no one reached out to her, right? And what we're seeing on our end, on the PICA side, is really in a lot of malpractice cases, it's not that the complication was avoidable. It's really that the response is what's getting scrutinized, right? Well, the perception becomes reality where Dr. Levick didn't respond to me. She doesn't care about what happened during the surgery she did, right?
Correct.
Really changes that trajectory. Let's zoom out, right? Like this is a great case because I think we've all been here where we've sat in the office and unfortunately the type A surgeons that we all are, we want to have control of these situations. But when you have a tertiary person like a staff or a front desk or someone who doesn't really follow your protocols that you set up, now it's not in your control, right? So if we zoom out, what are the most common ways you've seen where these types of post-op calls become bigger issues? Obviously, one, your staff doesn't tell you,
Right.
but where do we how do we navigate this? Like, how do we train our,
Right.
how do we do this so that this doesn't happen?
Right. This is a great question. There's these key performance indicators that I have in my own practice that are really important. And these are kind of like the red flags that we train our staff to listen to and to respond to immediately. And these are things that take precedence over patients that are even in clinic. I just roomed a patient. I don't care. We're ignoring it. We're not giving them their CAM, but we're responding to this key performance indicator, which is the patient is calling. They're giving a sign, whether it's that buzzword of diabetic, infection, shortness
Fever.
of breath, right, numbness, or I just had a procedure in the last 90 days, right? These are really important things. My to immediately put the patient on hold and come get me. There is no waiting. There is no little memo book that they write in. There is no hey, the doctor will call you back. There's none of that. It is an immediate response because things get lost in translation all the time. When people write things down, maybe that piece of paper gets thrown away. Goes in the shredder. They forget to even write something down. They don't write the telephone encounter that it happened. They don't send to the doctor. There's always that issue. So my rule of thumb is if they've had a procedure in those 90 days, they come get me immediately. And let's say I'm in surgery. I'm not in clinic. Then my rule of thumb is they have to text me immediately that patient is on the phone and that my OR, they are not allowed to get off the phone with that patient until me or my circulator or my resident texts them back and says, no problem, message received. So there is this like checks and balances where the person gets the message, they are responsible for it, but they've also communicated with me that this is an issue because there's only so many things that you can control, on a daily basis. And then there's the other aspect of it, which is, okay, I got the message, but I'm going to look at my phone and I can't do this right now. I get distracted by TikTok or I get distracted by
I hope
Instagram
not.
or I get distracted. I'm just kidding, right? That's not happening. But people get distracted all the time where there's another urgent patient in the clinic or I'm in surgery and I forget. Well, as long as I have that reminder, that text message if I'm in surgery or that I don't leave personally. So this is my responsibility that I'm putting on myself. I don't leave my computer until that telephone note is put into my EMR system. So the response is automatically documented and automatically there. And time is of the essence. So if it's a photo that's coming to me from the patient from an email, I have to respond right away. I do not go see another patient until I respond to that patient.
Yeah.
So there's this fire that I put under myself when it comes to post-op patients.
Yeah, 100%. I think we all have to do that, right? I mean, the patients have entrusted us in their surgical care, and having staff obviously trained well, right? I mean, you set protocols for your staff.
Like what you're hearing? Go ahead and subscribe so you never miss an episode again. Now, let's continue to connect on today's topic.
For us in our practice, what we do is we have patient cases that automatically, we don't use any papers, we don't use memos, we don't use Post-its. We went away from that probably about 11 to 12 years ago because this is exactly what we were finding is that patients would call and we wouldn't get the message. So the directive that our staff gets is you put in a patient case and there's a way to make it urgent, right? But let's say I'm in the OR. I'm not looking at my EMR and it's on my phone. Our staff is usually, and I say usually, trained to know that if it's a post-op patient with XYZ complaints, like you mentioned, or a diabetic, these things have to be escalated. So directly to me via phone call, directly to our on-call doctor, anybody who can answer that question. But at the same time, from a risk management standpoint, we have to talk about documentation, right? I mean, we have to be able to have this in a place where not in a text message, not in something that's sort of not part of the patient record, because we want to talk about how do we make this defensible, right? Let's switch the topic. Let's say your patient, Dr. Levick's patient called and said, my leg is really swollen and painful, right?
Right.
You didn't get that message. And now it's 2 weeks later, they're coming in. Well, I'm also short of breath and I have this little cough and I can't walk. Well, now we have this sort of delay in care. And how do we make this where, how do we document so that we know that things are going to be defensible? What do you make sure is in that note? I always tell my residents, like, this is not just a phone call, right? Especially from a post-op patient. It's a clinical encounter and we have to
Correct.
document as such.
And I would say 90% of those phone calls are, you need to come in right now.
Yeah.
Because if it's not a no, then it's a maybe, and that maybe needs to come in.
Yeah.
Because you can only see so much. These pictures are pixelated on an email or on a cell phone, or they're not giving you the whole picture. They're kind of like, I don't know, maybe my toe's blue, maybe it's not, I don't know, it could be just blood flow. Like, no, I need to put my hands on you.
Yeah.
That's why I hated telemedicine for that reason.
Yeah.
Like,
It's
how
very
can I
hard.
diagnose
Yeah.
through
Do
a
that.
Zoom or through, you know what I mean? Like, it's not appropriate. So again, that the extra layer of protection is having that low threshold where the patient has to come in to see you so you can put your hands on it. You can express the wound. You can actually palpate, feeling if it's hot or not, doing an actual Homan test to see if they have a DVT. Like, there's so many physical tests that you have to do to make sure there's not an urgent issue.
Yeah. I mean, I think the hard part really becomes is like, how much can one person, you're in a solo practice, right? I mean, this then becomes like a 24/7 project, right? Every patient is now yours for
Yep.
24 hours a day, right?
But really and truly, and talking about it from a liability standpoint, every single provider should feel like they're in solo practice. Whether you're in a hospital system or you're in a large group, ortho group, whatever, it's your responsibility. It's your patient. It's the person you cut open. So yeah, you need to be on call technically 24 hours a day, 7 days a week for these patients. And if you're not doing that, you shouldn't be doing surgery.
Yeah, I honestly, I don't disagree. I think the most successful people that are in practice right now are the ones who take every patient as if they're the only doctor that patient's ever going to see. Now, it feels ominous, right? It feels scary, especially if you're just coming out of residency or fellowship and now you're going into practice. This is maybe not what you're used to, right? Because when you're a
Absolutely.
resident fellow, you never see these patients, right? You don't see face of disappointment when they come in and they're like, well, I didn't think it would look like this. I didn't think it would be this painful. Right. So navigating and being able to communicate that, I think communication is probably the thing that sets everyone apart, right? That's what lowers
Yes.
the risk, not just empathizing with a patient, right? But actually making that patient feel validated, heard, that you care about what's happening in their postoperative
Yes.
care. I think that's a huge thing. And when we're
Absolutely.
documenting the story is probably the most important part, right? Because in the event that your patient is now becoming the plaintiff, right? We want to make sure that we have things in quotations, right? Patient said, I've had this XYZ from this time. I told them to start an antibiotic. I expressed if anything gets worse, go to the emergency room. Now, all of the things that we think are sort of second nature, I think have to be put into that story. So that narrative actually is something that's defensible, right? That's something that's going to,
Exactly.
God
Yep.
forbid, that there is a problem. I mean, when we talk about that post-op call that goes awry, right? I would say the biggest thing to reiterate is that reassurance without evaluation is really risk, right? You know,
Huge.
huge. You can
Huge.
you can say, "Well, I called Dr. Levick and she said everything's fine," and you never got eyes on it, right? I mean,
Right.
that's exactly what
Like,
you're saying.
listen, if you had a block, let's say you had a pop saphenous block, and the person calls and says, I'm having, numbness and tingling. Is that normal? Yes. You just had a block. The block's probably wearing off. If this gets worse, if you start to have abnormal amounts of numbness and tingling, it's not going in the way in the next couple of days. You need to come in sooner. Document it. But that's an obvious yes. Of course, you had a block. It's wearing off. Okay. But if you're having like pain out of proportion or you can't move your toes, what are you doing diagnosing over the phone? You need to come in, you
Yeah.
know?
I mean, I think on that note, and I think you jumped the gun, I am gonna do a little bit of a rapid fire. I really want, I want Dr. Instant. I
Okay.
want
Oh no.
I'm going to give you a scenario and I want you to tell me, what do you do? Right? Because this
Okay.
is one of
Okay.
the hardest things to navigate, particularly in a post-op patient, right? When you're first out of residency, I've been in clinical practice now almost 17 years. So I have a low threshold just like you. But in the beginning, I didn't, It was almost as if I would walk myself away from complications. Say, no, 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 that could never be the case.
Totally.
No,
Totally.
there's no way they had a DVT. There's no way. That's not happening.
Yeah.
You know,
Yeah.
I checked all the boxes. I looked at the risk, modification. The L trip score was this. There's no way. And then all of a sudden they're calling, right? They're calling. They're saying, Doctor, can you tell Dr. Patel, I just don't feel right. I don't feel good. This doesn't feel good. Like, what do you do with that? At what point are you going to say, come in? And I know you're going to say come in every time now, but
Yeah.
imagine. I mean, I feel like, do you think it matters the personality of the patient? Is this a high need?
That's a whole nother podcast,
We can talk about an hour for that one.
right? I mean, like people, okay, the older I get, the more selective I am with patients I do surgery on.
100%.
15 years ago, I'd take anything that would walk in. But there are certain parameters that I have in place, like there are fibromyalgia patients that I just won't touch. There are patients that have history of CRPS I just won't touch because I know there is that correlation. There is literature to support that those patients have a much lower pain threshold and they do not recover as well. And there's other complications that could happen. And I try to stay away from those types of patients. And you kind of get that feel in your preoperative assessment with patients. So like not every patient I'm taking is coming to surgery with me. But if there is a patient who is like unsure, and I get this more often, I wasn't sure if I should call you about this, or this probably shouldn't have called you. I probably, as a physician, make a bigger deal about it than they would.
Yeah.
And I think it does two things. Number one, it protects you as a physician. Come in. It's likely nothing. Just come in. I'm going to double book you today. Actually, just tell me what time you want to come in. I'll make it work.
Come in.
Just come in.
Anytime.
And it protects you, right? So you can see it, you can make sure. And I would say 99% of the time, it's nothing. On that 1% chance, like that's your license, right? That's you, right? But number two, that does something even more. It really builds trust between you and that patient. So let's just say that there is something that goes totally awry 10 weeks later. I don't know, they break their hardware, something happens, they fall. They know they can trust you. They know they can come in. They know that they feel comfortable with you. And I feel like that risk goes way down with them because you've built this incredibly strong, structured relationship with them. And you have this mutual respect. And they feel like they can tell you anything. They feel like they trust you because the first 9 weeks have gone so well. So I think it does two things.
One of the things that sort of reiterates is that access is actually part of care, but also part of liability. When a patient feels like they don't have access to you or there's some stopgap between their communication and the doctor who did their surgery, I think that is really a huge part of liability. Not feeling heard, feeling like they're dismissed, feeling like no one was listening when you're the surgeon who should be listening, right? Because you did the work. I mean, that's really that inflection point, right? Because the difference really isn't about the complication. It's really going to be the response, right? What did Dr. Levick, Dr. Patel do? Dr. Patel said, oh, don't worry about it. You'll be fine.
She blew me off.
There's
a reason. There's a constant theme when it comes to people with lawsuits, and that is people don't sue for what happened. People sue because of the way that the doctor made them feel.
Want to receive a monthly newsletter with topics from the Insured Connection? Head over to picagroup.com/Insured Connection and join our email list to have it delivered right to your inbox.
100%.
So if you're not taking care of them on a mental level, I don't care about physical things. Bad things happen all the time. I'm talking like that feeling like they're valued, the feeling that they're part of your family, that They trust you. They put all this faith in you. It doesn't just end in the operating room.
100%. I mean, that is one of the things that we really, PICA, from the risk management perspective, want to drive to our residents and fellows, because life will change once these patients are in your hands, right? They are yours. They are going to be like your family. These are the people you'll be thinking about when you're trying to go to bed on a weekend. But these are the people that will become your patients for life, right? Once you've operated, I feel like this is a commitment that you stay with. And it's so telling because there's patients now, I'm far enough in my career that I've seen patients come back, 10, 12, 13, 14 years later. They're like, oh, you did my other side. And it was so great. And I'm like, I don't even remember.
Yeah.
But, you
All the
put on,
time.
my God, so good to see you, because you have to kind of reestablish that connection, right? Particularly in those patients where things went wrong. And you look at these extras and you're like, oh my God, why didn't this become a case, right? Why didn't this litigate, right? You
Yeah.
don't have those days. I know you're not doing enough surgery, but there's plenty of surgeries I've seen that I'm like, I can't believe.
I'm so good with patients because,
Yeah.
man,
I,
some of these outcomes.
I know. And, patients, I think level setting their expectations from the beginning, right, is huge. And that's all part of the communication. I mean, that translates from before surgery, through all their post-op care, and then all of the communication we have afterward, right? If
Absolutely.
Dr. Levick is not accessible and she doesn't care about me, then why did I pick her, right?
Absolutely. And there's this other portion too that a lot of my residents talk to me about. They're like, well, we noticed, Dr. Levick, that you give your cell phone out. Well, hold up. I don't give my cell phone out. When the patient calls, there's a button that they push, which will be directed to my cell phone. They don't know that number, right? But patients that do have my number, it's not a direct number. It's like a Google number, which goes to my cell phone. But there are these residents that are getting jobs in large hospital systems that don't have that type of constant communication one-on-one with their patients, and it gets lost in these large organizations where you might tell one nurse, which goes to the call center, which goes to another nurse. Which the bottom line is that I don't care what system you're in, and this is what I tell my residents all the time. It is your license. It is your name on that op report. It is your name on those post-op appointments and on all of those telephone encounters that are directed to you. So you better find a way for those patients to get a hold of you, whether it's having a pager, for God's sake, something that patients are able to get a hold of you, because these systems are too large for their own good. And so if these patients aren't able to communicate with you, like, it's just a recipe for liability and disaster.
100%. I mean, this is like the difference where it's the moment where like reassurance of a patient, reassuring your patient replaces curiosity, right? God forbid that patient starts going down the Facebook rabbit hole, right?
Oy.
Of all the procedural groups that are on Facebook or ChatGPT. ChatGPT
Mhm.
said XYZ. It's where efficiency of being an efficient provider, surgeon replaces just listening, right? Where we have to understand where these patients are coming from. And I always say, if you're going to, use like ChatGPT or Google, just call me directly. I'm your direct source. You don't need to do all of that. Right. Um, because patients really, and this is probably the truest thing I will say about any encounter with a patient, is they don't remember what you did, right? They probably don't even remember what surgery they had, right? They're going to remember whether they felt heard. Dr.
Mhm.
Levick understood my pain. When they don't feel heard, that's when these complications really become complaints, and where complaints turn into claims, right?
Of
That
course.
that is it. I mean,
And
a
I'm going
patient,
to take that a step further.
yeah,
If you practice in your own community, that word will get out and you will lose patients. This is not just a liability impact. This could be a financial impact for your family. This could cause your practice to close. I mean, there's so many other ramifications this could have for you other than just, potential lawsuit. This goes beyond that.
and I 100% agree. Especially if you're not only if you're in a private practice, but even in these larger groups, right? You don't want to be that person who doesn't respond to the patient, right? Patients have lots of ways to putting their thoughts about you as a provider into the ether, right? Into the universe.
Yeah, totally.
Between Google, Yelp, health grade. I mean, every single thing everything's rated. This is our like, comment, and share generation, right? They will find you, they'll find your page, they'll post it, they'll put your picture, your headshot, and it will really become one of those things that, if you took the 5 minutes to answer that phone call, you could have saved yourself all this trouble.
Oh my God. Yes. 100%. Yes.
100%. I mean, we all know, just like as a little final takeaway, because I love that Dr. Levick was so open and honest about these kinds of situations that happen, and we sort of don't like to talk about them because they're uncomfortable. But, we all know as foot and ankle surgeons that complications are going to happen, right? It's just part of surgery. If you do enough cases, you're going to find it. It's a statistics thing. What really resonates to me is it's how we respond to these complications. That's really where the risk lives, but it's also where we have the most control, right? We can't control what our staff does typically 100% of the time. We can't control what the patient does, right? Because I'm not going to walk. I'll stay in the boot. Yeah, doc, I'm not walking. And then, they show up in a flip-flop 2 weeks after a bunionectomy. Doesn't make any sense. What we can control is when things do go wrong, we can actually mitigate our responsibility and our risk, which is the biggest thing. So, all of the topics we talked about, Dr. Levick, it's so amazing that you're able to share this such a sort of vulnerable story, because we all go through these situations with post-op patients and we hate it. It's uncomfortable. Patients yelling at you about what's happening in their post-operative time, and we just don't want to talk. But if you had to give one piece of advice to any resident or fellow or young practitioner listening to this podcast about postoperative care and sort of how to mitigate risk, what would that be?
That's a great question. This is going to bring out my Zennial side.
Love it.
It's like Biggie. I can't believe I'm saying this on here.
You are. Yeah.
But there's this song, and these things go through my head when patients call. Sometimes songs just pop in my head. And one of them is if you don't know, now you know. And it's that, those lines go through my head. And it's, if you don't know something and they don't know something, the patient doesn't know something, your MA doesn't know something, I don't know. If you don't have that 100%, this is not a problem, don't worry about it. I'm talking 100%. If you're at 99%, you have that patient come in, low threshold. You have them come in, you put your hands on them, because 99% of the time, you're going to be right. It's not a big deal. But if it's that's your name, that's your license, that's your
reputation.
Your reputation. That's the connection you have with that patient is lost. So you better bring them in.
I love it. Just to close out, first of all, I'm a fan of a Biggie reference. So obviously we're best friends, but going back to our topic, it was just a post-op phone call. Well, most malpractice cases don't begin with a catastrophic error, right? They begin with a moment. It's that moment where you didn't know, right? A missed signal, a rushed conversation, a patient who really just didn't feel heard. The good news is we also have opportunity to change the outcome, by doing all the things we talked about, right? Making sure we have protocols in place, making sure we document, making sure we listen to the patient, practice empathy, be kind, and really make that patient feel heard, understood, and create a solution. It's one of the things we didn't go back to, is that you had a solution for this patient before you walk back into that room.
Yes.
Patients are looking for a leader, right? You are their surgeon. You're the one who fixed this. They want the leader to now take them to that next step, that next level. How do we make this better? Dr. Levick, you are amazing. I absolutely love talking to you, and I can't wait to record more of these podcasts. I don't know what the topics are, but we can just talk for our music taste if you want. All good with me. But to our audience, thank you so much for listening to the Insured Connection. When we understand risks, we don't just protect ourselves, we take better care of our patients.
And that's it for this week's episode. But let's continue connecting. If you're enjoying the Insured Connection, don't forget to leave a review on your streaming platform and subscribe now so you can connect with us each time we post a new episode. To stay connected with us throughout the week and to tell us topics we should discuss on future episodes, go to picagroup.com/Insured Connection.